Do I need to stop sharing my screen?
No, you're okay. Good evening, everyone. You're very welcome to tonight's family webinar, Navigating the Pathway from Memory Problems to a Diagnosis of Dementia. We're really delighted to have Dr. Sarah O'Dwyer, one of the consultant psychiatrists, a specialist in general adult and later life psychiatry within our service, joining us this evening. It's great to see so many of you trickling in, and we'll just give it a moment to let people join. As with other webinars, we'll have some time at the end for Q&A, so please feel free to pop any questions into the Q&A box. We always stress that sometimes difficult emotions might come up, or if you feel upset at any time, please feel free to take a moment to do whatever you need to do to make yourself feel comfortable, safe in the knowledge that the webinar is recorded and you can go back to it at a later stage if you need to. The webinar will be uploaded to the website in the coming days, so if you want to rewatch it again, it will be there for you. So without further ado, I'll hand over to Dr. O'Dwyer for what's going to be a very interesting presentation.
Okay, great. Thanks, Elaine. So welcome everybody, and I'm delighted to be here with you tonight. And the aim of this talk really is to provide, I hope, some very helpful and practical steps in how you navigate the pathway really between memory problems to a diagnosis of dementia. And it's really aimed at individuals who may have concerns themselves about their own memory, or who may have a loved one or a family member that they have concerns about also. So to begin with, this is just a brief overview of what I aim to cover in this talk. So we'll talk a little bit about what memory and cognition is to begin with, because to have an understanding of what can be deficit or what you're losing as you progress, let's say, to a diagnosis of dementia, first of all, it's really important that you have an understanding of what memory and cognition is in the first place, an understanding of our mental functioning and the different domains that we can assess and measure our ability to think and perform tasks, and how they can change as we develop memory or cognitive deficits. I'll speak a little bit about how memory and cognition can change as we get older, and I'll talk a little bit about whether that's normal or not, whether it's age-related or whether it's actually heralding or a symbol or a sign of something more sinister occurring. I'll talk a little bit about when you need to maybe start worrying or develop concerns about what you're experiencing or what you're noticing your loved one experience in relation to deficits that you're observing from day to day. And we'll talk a little bit about, if you do have concerns, what you need to do and how you seek help. And if it is the case that you require investigations for memory complaints, what's involved when you go and see your doctor, from a very simplistic point of view, very simple explanation of what the actual process will involve, and then what the possible outcomes of those investigations will be. And it may be the case that you have nothing to be concerned about, and that some of the difficulties are related to your age as we grow older, or that you may be given a diagnosis of mild cognitive impairment or a diagnosis of dementia. And I will talk about the different types of cognitive impairment, mild cognitive impairment, MCI, and the different types of dementia also, and how they can present and manifest. And when you receive a diagnosis of dementia, it can be a very scaring time for someone. It can be very disconcerting, and people often don't know what to do when they receive a diagnosis. So I'll give some tips really about moving forward, how you manage a diagnosis and what you can do to access resources and how you can manage that. And ultimately, and one of the main focuses I would hope of this talk is really about having a very positive spin on this and highlighting the importance of optimizing your brain health, because there's a number of factors and a number of lifestyle choices that you can engage and ascribe to that actually can significantly reduce your risk of developing memory problems and dementia, and even slow your progression if you do develop or given a diagnosis of dementia. Okay. So to begin with, as I said, I think it's very important that we have an understanding of what memory and cognition is, to have an understanding of what is being lost if we do develop difficulties with our memory and cognition. Okay, so if you take it looking essentially inside the brain, when people complain of memory deficits or memory conserves, it's very much a catch-all phrase. And oftentimes someone can be presenting with deficits or difficulties with memory and forgetfulness. But on many occasions, their difficulties are not purely related to memory, and other cognitive domains might be involved also, okay? So our ability to think, our mental functions, our thinking abilities, our thinking capacities are divided up into 6 main domains. And those main domains are often the responsibility of different lobes within our brain, okay? And these deficits can be measured and can be assessed, which is what happens when investigations are carried out if someone feels or is concerned about memory complaints. So to begin with, and the one that's most commonly considered is the concept of memory and learning. And memory is essentially our ability to remember data that's coming to us at all times throughout the day. And that involves both working memory, short-term memory, long-term memory, which I'll talk a little bit more about, and the ability to encode, which is to set down and bed down memories, and then to be able to retrieve those memories, which is to be able to recall those memories at will. So for example, in a condition like Alzheimer's dementia, there's a difficulty with your ability to form short-term memories, but your ability to recall long-term memories is often really preserved even to the later stages of the condition, okay? The second domain is attention, and that's ability to focus or sustain our attention on a topic or on a piece of information or on a task. And as we get older, that begins to decline, and that essentially is age-related, okay? But then in certain conditions and in certain types of dementia, that will be more impaired than in others. Executive functioning is our ability to carry out goal-directed behaviors. It's our ability to problem solve, decision make. It's our ability to have what's called mental flexibility. So our ability to move from one task to another within our brain within a very short period of time, okay? It's our ability to be able to regulate our emotional responses to certain circumstances. And our executive functioning is mainly managed and controlled by our frontal lobes, which are basically at the front of our brain, essentially. Language is another domain, and that's our ability to understand the written and the spoken word, our ability to be able to formulate thoughts and to be able to communicate them in words and use vocabulary. And in certain conditions, particularly, let's say, frontotemporal dementia, our ability to be able to propagate language, to be able to understand the spoken word, to be able to understand the written word, and to be able to communicate verbally can become impaired. We then have the concept of social functioning. And again, like executive functioning, it's our frontal lobes that are mainly responsible for this. And that's our ability to interpret social cueing, to be able to be aware of the dynamics that are occurring within a social setting, to be cognizant of dynamics that are occurring between different people, and to be able to modulate our emotional responses or our behavioral responses in response to that. And then visuospatial skills is our ability to have an understanding of the visual and spatial relationships between our own body and the world around us. So for example, certainly in Alzheimer's dementia, on occasions, people can develop deficits in their visuospatial skills, and they're the individuals who are more likely going to have falls, they're more likely to walk into things, and they're particularly more likely to have accidents in their car. So they'll come complaining of having multiple scratches or multiple tips to the car. So when we're talking about memory deficits, we're often not just talking about memory. Memory is only one domain. We're actually talking about deficits that can occur in all of these domains. And in certain types of mild cognitive impairment and in certain types of dementias, deficits can occur in different domains to different degrees, depending on the type of dementia. And I'll talk a little bit more about that, okay? So I think it's very important, as I said, to have an understanding of what you're losing in a condition like dementia, such as Alzheimer's disease. It's really important to understand what memory, and in particular what memories are and how we form memories, because it really is a fascinating process. So memory is our ability to remember everything. Our ability to be able to function from moment to moment within our lives is based on us having learned skills, having learned information that allows us to function, okay? Not all memories are made the same. We have different types of memories. We have, as I said, our working memory, short-term memory, and we have long-term memory, and there's different types of long-term memory. So for example, autobiographical memories, which are memories about our life, we're far more likely to embed and store those in the filing cabinets within our hippocampi, which is within the temporal lobes on either side of our head, because we make stronger network connections. These neurons, which are the cells within our brains, they're activated more strongly when we have a memory that relates specifically to us or our personal circumstances. And that's why someone, for example, who has Alzheimer's dementia, they are more likely to remember and to recall longer term memories, because we embed and encode those memories more stronger over time, let's say, compared to other memories. So creating a memory involves several steps. And the problem with someone who develops mild cognitive impairment or who develops dementia is that there can be basically problems in this sequence of events. So the first step is acquisition, and that's actually acquiring information. And that information comes to us through senses. Okay, so it could be hearing, it could be visual, it could be through touch. Okay, and when we form a memory, it really initially will be in our working memory. So our working memory is what allows us to function. It's what allows us to navigate information for a very short period of time. So right now I'm using my working memory. I'm looking at the screen, I'm prompted by words, I'm retaining information for several seconds to communicate it. And that's my working memory. We then make a decision about whether that information or data we want to store in our short-term memory, okay? And then if we decide that this is information that's actually of value, we make a decision to store it into our long-term memory. But different areas of the brain are involved in that, and storing it is what's called consolidation and encoding. And retrieving is our ability to take it out of the filing cabinet, okay, and at will, and recall it at will when we need to do it. So different areas of the brain, as you can see on this picture, are involved in that. And the ones I suppose I want to point out most importantly are the temporal lobes and the hippocampi. So the hippocampi are these two tiny areas that are in our temporal lobes, essentially behind our ears and the side of our head. And there are memory seats, okay? They're primarily responsible for storing long-term memories, okay? And they're essentially like filing cabinets. And when we store memories, we file them into this filing cabinet, and then we go to that filing cabinet and we retrieve the memory at will when we need to do it. With someone who has dementia, that can become problematic. The other issue, particularly in Alzheimer's disease, is the ability to form short-term memories and encode them into long-term memories becomes really tricky, and hence why we don't then form very strong memories, because that initial step of forming short-term memories becomes impaired. The amygdala, again, is part of the temporal lobe, and that is responsible for our emotional overlay. So if we have a memory that's very strongly associated with an emotional experience, some of the data from that memory will be stored in the amygdala, and the cerebellum is responsible, let's say, for storing movement. So for example, if you have someone in advanced stages of Alzheimer's, they may not be able to tell you the date, they may not be able to tell you what they had for breakfast half an hour earlier, but they may have no problem brushing their teeth, because the memory of how they brush their teeth is a longer term memory, but it's a procedural memory. That isn't stored in the hippocampi, which basically begin to shrink in Alzheimer's disease. That's stored in their cerebellum, which isn't affected until the very later stages of Alzheimer's and end stages of Alzheimer's. Okay, so the next question is, can therefore forgetfulness be normal? Can having deficits in your memory be what's called age-related? And the answer to that question is yes, because a lot of people come and think, oh, I'm worried about my memory, there has to be something wrong with me, there must be a disease process at play. And that's not necessarily the case at all. As we get older, our brains are simply not as good at doing certain tasks. Now, I will talk at the end of this talk about what we can do to modify that risk and to cognitively train our brains to be better at doing tasks. But naturally, we do have deficits as we get older, okay? So you can see here in the graph, the first one refers to normal age-related memory loss. So as we enter our 60s, 70s, there's going to be some natural occurring deficits in our ability to remember, and also in some other cognitive domains. And then the lower graph is basically what happens in Alzheimer's disease, which I'll talk about a little bit later in more detail, but that's where you're getting a sharp decline in your ability to basically form, in particular, short-term memories. And then as the disease advances, you lose the ability to recall longer-term memories as well. So when we talk about, well, okay, what's normal then? So if as we get older, our memory can become impaired, what's the difference between abnormal and normal? What are we still good at? What do we preserve the ability in doing? And what becomes a problem? So what we're good at doing, okay, is, as I said, long-term memories, the ability to recall events from longer term. They're stored in your hippocampi. It's a filing cabinet. We can recall and take those memories at will when we need to. We're quite good at doing that, even in advanced stages of some types of dementia, okay? Procedural memory, as I said before, is also something that we really do preserve quite well as we get older. And that's the ability to perform tasks such as riding a bike. You may not have ridden a bike for 20 or 30 years, but when you get on the bike, you're able to ride the bike, okay? That's because that memory is set down as a procedural memory, a specific type of long-term memory, where the data is then extracted from different areas of the brain, the frontal lobes, okay, the back of your brain, your visuospatial abilities, and we reassemble that memory, which allows us then to be able to cycle a bike, even though we may not have done it for years, okay? Semantic recall is basically very much dependent on your academic attainment, okay? So it's the general knowledge or exposure to learning over the years, and vocabulary. And vocabulary is your ability to take words and to take language and to manipulate them into phrases and to sentences that you can use to communicate, let's say, your will and preference, or to communicate information to others. And semantic recall and vocabulary are very much what are referred to as crystallized intelligence. And crystallized intelligence is our ability to problem solve and to take information and to navigate that and to form a decision based on acquired knowledge, okay? And it's very much dependent on your previous exposure to knowledge. And those abilities we retain really right up into our 70s and 80s, okay? What begins to decline, though, as we get older into our 60s and 70s, is our ability to form new information. So our ability for our working memory to work as effectively, and then also for us to recall new information. Because if we struggle to learn new information, we then struggle to navigate from working memory into short-term memory. And if we don't transition information into short-term memory and then learn to store that to be able to retrieve it, it can be very difficult then. It takes longer to recall new information that we have received from our environment. And other cognitive domains that can be affected by aging is language, okay, executive functioning, and in particularly processing speed. And processing speed and executive functioning in many ways are a measure of our fluid intelligence, and fluid intelligence isn't dependent on academic attainment. It's the concept of nature versus nurture. Nurture is what our crystallized intelligence is about. It's what we have learned through our previous exposure to education and knowledge. Fluid intelligence is that it's genetically, it's inherited. It's just our ability to have higher abilities to use our cognitive abilities to solve problems without previously acquired knowledge, and that's referred to as fluid intelligence, and it's a measure really of your overall general intelligence. So this is a perfect example of what processing speed is, because this is one of the key deficits as we get older. So for example, you can see in the first key you have icons or symbols with corresponding numbers, and the part of the test which would be timed, which would be to replace basically the symbol with a number. And our ability to do that really maxes out in our early 20s, okay? And as after 20s, it's kind of a downhill pattern. So for example, an average 20-year-old will do this 1.5 to 2 times faster than an average 70-year-old. And that's not because of a disease process, that's simply age-related changes and our inability or our processing speed slowing down. Okay, so if it's the case then that some memory deficits and some cognitive deficits can be considered normal, where does it reach a point where you go, okay, well, is this a problem? Is what I'm experiencing or is what my loved one's experiencing normal versus abnormal, okay? And this slide is really to give you a sense of what should be considered normal versus abnormal. So for example, let's talk about temporal orientation, knowing the time and date. It's normal to forget the day. It's normal for me to think maybe today is the 9th of November, but I'll know, it's November and that it's 2022. What's not normal is for you to ask someone and for them to tell you it's the 6th of April, 1987, which is something I would regularly hear from patients who have cognitive deficits. So no awareness of temporal orientation, okay? Having the day wrong or off by a day or two is not very concerning. Occasionally forgetting someone's name, acquaintances that you may not see very, very often, and when you meet them, you just doesn't come to the tip of your tongue. It's you just can't think of their name, but you clearly recognize their face. That's normal. That's a normal process that happens to people at any age. Regular forgetting of family members or even acquaintances that you don't know very well and not recognizing their faces, that's concerning. There's a problem with that, okay? Slower at solving a problem or a riddle or navigating a problem. As I said, that's fluid intelligence, and that naturally begins to decline as we get older. That happening every now and again, or as you're hitting into your 70s or 80s, it can be normal, it can be age related. Being unable to comprehend a problem, unable to navigate a problem whatsoever, that is not normal. Okay, that's concerning. Having difficulties with new technology. So if it's some type of voice activated, Bluetooth mediated technology, I wouldn't be able to use it. That's normal. What's not normal is not being able to use the TV remote control, or being able to, let's say, navigate the washing machine when you've been doing it and using the same machine for a number of years. That would be a concern. Other things would be struggling with orientation in a strange or a new location. That can happen to a lot of people no matter what their age. What isn't normal is when you start to struggle with a familiar environment and you can no longer, let's say, map a journey and travel a journey to the local shop when you've been doing it for 20 years and you find that you're becoming forgetful. Okay. Repeating yourself every now and again. So telling a funny joke or story to a group of people that you saw 6 months ago, and then you happen to meet them again 6 months later, and you forgot you told them the joke. That can happen to anyone. What's not normal is when you repeat yourself and you don't have awareness of it, and you're doing it within the day, or you're asking the same question of your loved one or your family member, and you're not aware that you've asked that question, let's say half an hour earlier. Okay. Misplacing random items, we all do that, but you're usually able to retrace our steps and find them. What's not normal is where you're losing these items and you actually have no recall of where you put them. Okay. As I said before, if someone has visuospatial deficits, every now and again, we can randomly, because of distraction or whatever, lapse in memory, kind of isolated tip or scratch to the car. Regular tips and scratches to the car is often a sign of concern. Not thinking of a word from time to time, which can happen at any stage, happens to me even during this conversation or this talk. That can happen when you just can't think of the word that you want to use. That's normal. What's not normal is where you have very significant word finding difficulties occurring in a conversation, and you're finding that you're searching for a word in order to even allow the conversation to be fluid and to be able to engage in a reciprocal conversation. That's not normal, and that's something that would be concerning in general. So if it's the case that someone is complaining of these deficits and has concerns, like what are the possibilities? Well, the possibilities are that it could still be age-related deficits, okay? It could be that they're kind of lapsing into the cusp of mild cognitive impairment, which I'll talk a little bit more about, or it could be that someone is moving along that trajectory to a diagnosis of dementia, which I'll talk a lot more about as this talk progresses. And this graph is really just showing you the idea of what normal aging is. So there is this kind of very, very gentle slope in cognition. Mild cognitive impairment is a more steep slope, and obviously then a more acute slope where you're moving down into dementia. Here it just refers to prodromal AD, which is Alzheimer's dementia, just as one, but that's only one type of dementia. We'll talk about several others. And preclinical, what that really refers to is that sometimes people are presenting with symptoms before there's a clinical manifestation. So having age-related difficulties can be age-related, but it can potentially be flagging that there is something more progressive, and age-related difficulties can progress into mild cognitive impairment, which is an actual diagnosis, and then that can progress into dementia. And we'll talk about the rates of how that happens as things move forward. So if you are worried and you're concerned that you have some of these deficits, and you've been worried about your memory or that of your friend or your loved one, what do you do? And the key to this is you seek help, and you seek help early. You don't sit on this. And the real reason for this is that, one, it may be age-related and it's something that just needs to be monitored, and that can be really reassuring. The other reason why it's important to seek help early is that sometimes these deficits can be reversible. And so it's really important that it's investigated as early as possible, because if it is reversible, it's important that that's addressed and managed proactively. So what do you do? Well, the first thing you do is you contact your GP. Okay, so you engage with primary care, you make an appointment to see your GP. So what's your GP going to do? You're going to attend your GP and you're going to say, listen, I'm really worried about my memory. Now, it may very well be the case that you're worried about your memory, but potentially there's deficits in those other cognitive domains that I spoke about. So your attention, executive functioning, visuospatial, etc., that you may just not be aware of, but you're just using that all-encompassing term of memory deficits to describe what the difficulties are. So the GP is going to listen. They're going to take a history. They may do a physical examination. They may take blood tests. They might do some memory screening, which I'll talk a little bit more about. So that's very brief screening to give them an idea of whether there's something of concern. They may and are likely to send you for a brain scan, particularly a scan called a CT brain or an MRI brain. Okay, and I'll talk a little bit more about that. And they may consider medications, but they may not, really depending on your presentation. And they also might provide you then with more information about support services and organizations. Some GPs then will refer on to specialist services, such as the memory clinic that myself and Dr. Lyons run here in St. Patrick's Hospital, or sometimes geriatricians, as well as neurologists, as well as old age psychiatrists, assess individuals who are complaining of memory problems. And often a referral to specialist services is more likely to happen if you're of younger age, or if your presentation is concerning, it's rather atypical, or if in particular there's a rapid decline in the deficits over a short period of time, and there's concern that there's something more going on. So when you go to see the GP, the first thing the GP is going to do is take a list of your concerns. And the reason for that is because they need to determine whether this is something that they need to flag. Is there something of concern here? And there's certain conditions that are more high risk associated, or higher risk of association with dementia than others. And therefore, obviously, existing mild cognitive impairment. So if someone has already an established diagnosis of mild cognitive impairment, they're already along that trajectory towards a diagnosis of dementia. So they're obviously at increased risk inherently of progressing along that pathway. Having a strong cardiovascular history, okay, so that's high blood pressure and high cholesterol. Post-stroke, which is going to have the same risk factors as someone who's got strong cardiovascular risk factors. So if you've already had a stroke, you're going to have damage to your brain, and you're going to have hypoxic changes, which is areas of the brain that haven't had enough supply of oxygen because of hypoperfusion. And that leads to certain neurons dying off. And if certain neurons die off, it can lead and manifest and present with certain deficits in both memory and other cognitive domains. Having a positive family history of dementia, so there's a genetic component, particularly to Alzheimer's disease and some other types of dementia, which we will talk about. Down syndrome is a risk factor. So individuals with Down syndrome, they carry an extra chromosome, and on that chromosome is one of the main genes associated with Alzheimer's disease. So people with Down syndrome, about 30% by the time they're in their 50s will have Alzheimer's disease, and by the time they're in the 60s, over half will have developed Alzheimer's disease. Excess alcohol use is a significant risk factor for developing alcohol dementia, but also vascular dementia, because excess alcohol use in itself increases your cardiovascular risk factors, so it pushes up your blood pressure in particular. Nursing home residents, primarily because they usually have chronic illnesses, comorbidities, they're usually an older cohort, and age is a risk factor for developing dementia. Patients with underlying neurological conditions such as Parkinson's disease can develop a particular type of dementia, and I'll talk a little bit about that, and Lewy body dementia. And people with Parkinson's disease, up to 80% will develop dementia in the advanced stages of their condition. And then a history of head injuries and concussion, and that's probably something that's quite new and novel in more recent years. If you have particularly rugby players, American football players, it previously was referred to as like the punch drunk syndrome or the boxer syndrome. But when you have multiple head injuries, you can develop a specific condition called chronic traumatic encephalopathy, which is a condition that you specifically see in certain sports individuals who have had repeated high impact head injuries. So as I said, when you go to see the GP, they're flagging to see if you're falling within the high risk category for having developing a dementia. And then they're going to do some other things. One is going to be blood tests, okay? And they're looking for specific things in the blood to see if there's any possibility of reverse. So low vitamin D, hypothyroidism, they're both associated with developing cognitive slowing, reduction in processing speed, short-term memory deficits, and they're reversible conditions. They'll check your blood pressure because of the risk of cardiovascular conditions, and they'll also review your medications, okay? And aim to streamline your medications, because certain medications are associated with kind of cognitive blunting and cognitive slowing, okay? So as I said, the main reason for doing all of this is because you want to identify if there's something reversible, and you need to proactively address that. So the three main, to break it down and make it very simple, I refer to them as the 3Ds, the 3Ds that are responsible for causing what I call reversible memory problems are depression, drugs, as I mentioned, and delirium. So I want to just talk a little bit about depression, and particularly in older adults. Depression in older adults can present with what's known as a pseudo dementia or a fake dementia. And up to 30 and sometimes up to 60% of older adults who present with severe depression will present with short-term memory deficits, poor concentration, poor processing speed, and a sense of cognitive brain fog, okay? And it mimics or masquerades as a dementia, but actually it's the depression that's causing this. And depression should be very proactively treated in older adults, because when it is treated, all of these symptoms of the pseudodementia will resolve essentially. Now, with that said, when older adults have significant episodes of illness, such as depression, and if they've repeated episodes, it does increase your risk of having dementia as well. More of a reason why it should be proactively managed and treated aggressively, okay? The second is drugs. So certain medications, certain blood pressure medications, certain statins, which are given for high cholesterol, certain medications for anxiety in particular, and certain medications, anti-seizure medications, all can cause cognitive slowing. So it's about looking at what medications you're on, and particularly in older ladies, medications that are given for bladder incontinence, they have these what are called anticholinergic effects. And a large proportion of older ladies will be on these medications because of incontinence, but they can cause significant cognitive slowing and reduction in concentration. And these medications need to be reviewed and stopped if possible, and it can alleviate some of the difficulties. And then acute delirium, which is an acute confusional state that is reversible. It's usually caused by an infection or constipation, particularly in older adults. Having a diagnosis of dementia increases your risk of developing a delirium. You're more vulnerable, but also if you've had multiple episodes of delirium, you're more likely to be at increased risk of developing a dementia. So it's kind of a catch-22 scenario there where you're vulnerable both ways. And then, as I said, other conditions such as hypothyroidism, vitamin B12 deficiency, again, older adults can experience this. It's known as pernicious anemia, inability to absorb vitamin B from the bowel, again, very easily managed by replacement, chronic illnesses, and as I mentioned, alcohol dependency and misuse. And I specifically want to mention sleep apnea, because sleep apnea is a condition that's simply just missed and underdiagnosed in a huge portion of patients who present with cognitive deficits. So sleep apnea is a respiratory difficulty, and it's where at night when you're sleeping, you hold your breath, okay? And when you do that, it prevents proper oxygenation and perfusion of your brain. And when this happens over a long period of time, it can cause neuroinflammation, so inflammation of the brain, but it also can lead to what's called these hypoxic changes, where tiny neurons in different areas of your brain begin to die off. And that can lead not only to what's known as a vascular depression, but also can cause a vascular dementia. And it's very easily manageable. They estimate that up to some portion between 17 to 50% of older adult males have sleep apnea that isn't diagnosed. And there's up to about 20% of females who present with restlessness, feeling of being unrefreshed from their sleep, or nightmares. And it's actually a diagnosis of obstructive sleep apnea. And given the fact that it's very reversible by treatment and management, it's very important that if you have any concerns about holding your breath at night, or someone mentions it to you, that's investigated, because again, as I said, it's a reversible cause and can lead to dementia if it's not managed proactively. So the screening then the GP might do is one or two of these. These are the most common screenings. So if you go your memory deficits, you've had your physical examination, they've talked to you about your difficulties, they've done the blood test, they might say to you, okay, we're going to do a quick screening. These two tests take less than between 10 to 15 minutes, okay? And they're basic screening to look for deficits. Now, if someone has a very high academic attainment and pre-morbidly is of high intelligence, they may actually score very well on what's known as the mini mental state examination. It's a very quick test. It's basically assessing your short-term memory, some of the other domains, but in a very brief way. It's scored out of 30. A score over 27 essentially is normal. Between 20 to 27 suggests mild deficits. Between 10 to 20, moderate, and below 10 would suggest significant deficits. The Montreal Cognitive Assessment Tool is a tool that GPs often use as well. Again, it's about 10 to 15 minutes. It's scored out of 30. And as you can see, the first part of it is looking at executive and visuospatial, which are those domains that I mentioned previously that aren't tested for as well in the mini mental state examination. So sometimes people who are scoring quite well in the mini mental, this test, the Montreal Cognitive Assessment Tool, will catch them because it's assessing for other domains that the mini mental doesn't assess for. So as you can see, the first involves a trail make. So you're asked to basically draw a line between a number and a letter in ascending order, ending with the letter E, and seeing whether you're able to do that. And a lot of people will have significant difficulty with that. Draw a 3D cube and then draw a clock and fill in the hands at 10 past 11 or 10 past 10, and then confrontational naming of what's known as low frequency words. So a lion, a rhinoceros, and a camel. They're low frequency words and it's confrontational. So you're saying to someone, name these now, and they have to think of the word, okay, and then name it. And often people have difficulty with that. And low frequency words are words we're not using in everyday language, not necessarily going to say camel every day, versus high frequency words like sliced pan or milk or toast or work, or words which we use more regularly throughout the day. So often these will then highlight deficits and concerns, and that may prompt your GP to look for a specialist referral. So if there's concerns and there's deficits and they're wanting to have a specialist opinion, or as I said, if you're of a younger age, so someone's presenting these deficits and scoring low in these, let's say, and they're in their 50s, or there's been a rapid change in a short period of time, like 6 months, they'll make a referral, let's say, to the memory clinic here, or memory clinic in St. James's, or memory clinics all over the country, and different specialists, as I said, will run these. And when we do formal neuropsych testing, that's far more intricate and intense testing than those two tests that I just showed there. This is pen and paper testing that's done with the neuropsychologist, and we're looking at 3 to 4 hours of testing, okay? Now, you usually take a break, you do about 2 hours, you take a break, and then you do another 2 hours. And this type of testing is very intricate testing where you're examining and you're assessing and measuring skills within all of the domains, the memory, the visuospatial, language, attention, and executive functioning. And you're looking to show specific and discrete deficits. And by doing that, it can help us to identify if you have a specific type of dementia. Okay, so having this type of what's called formal neuropsych testing can be very helpful if there's a concern or a query, or there isn't clarity about the symptoms that you're presenting with. What's essential in order to really make a diagnosis of dementia is a brain scan. Okay, so here on the left is an MRI, and an MRI is far better than a CT for helping us to be able to differentiate and identify if there's evidence of change in your brain. So what you're looking at on the screen here is an MRI scan. So the top screen, I know it probably doesn't make much sense, but what that is it's basically called a coronal image, and it's basically a scan looking through here, through the different slices this way, whereas the one on the bottom is an axial scan, and that's looking from the top of the head and looking straight down through slices through your brain this way. And what you're looking at in the top one is on the left-hand side is a normal, very full, healthy brain. And on the right-hand side is a brain that is shrunk, okay? And there's evidence of atrophy. So you're seeing larger gaps and more black, which is basically the fluid, the cerebrospinal fluid around the brain. And that is the type of changes you see in someone who's developed a dementia, likely Alzheimer's disease. And in the lower one, I put this one up to show you what vascular changes are. So those white capping, or those little white punctuate dots that you see on those scans, they're evidence of vascular changes. So within that white area, those cells have died off because of hypoxic changes, tiny little miniature strokes that have happened. And depending on where those little tiny strokes happen, can cause specific deficits in different neurons, which will present then with different cognitive deficits. And this is just to give you an example of how the brain changes. So a perfect example is an Alzheimer's disease. You look at a normal healthy brain versus an Alzheimer's brain. So what you're looking at is all of those folds, okay, are basically called gyri, and between them is the sulcus, or the gaps. And in someone who has an atrophied or shrunken brain, which is what happens in Alzheimer's disease, because the brain is essentially deteriorating, the brain shrinks and the gaps between the sulci become much larger and much bigger. And the main areas that are impacted are your temporal, okay, which is behind your ears, and that's where your hippocampi or your memory seats are. That's the first area that's affected, okay, and the cells begin to die off there, and that's what leads to the difficulties with memory, primarily in Alzheimer's disease. And it's only as other parts of the brain begin to shrink later on in the disease that other domains become affected and other deficits become evident. So if you've had all of these investigations, you've taken the history, you've had your scan that shows evidence of some shrinkage of the brain or some vascular changes in the brain, you've had your blood test, and you are now at a point where all of this information is taken together, and maybe formal neuropsych testing has been done too, or the brief screening has been done. All of that information is taken together and it's used to inform what's known as a consensus diagnosis. And what are the possibilities? Well, the possibilities are that you have age. So in the memory clinic here, this is what we're usually seeing. People who have age-related memory deficits, and we reassure them and say, let's just monitor this and see how things go. People may present already along that trajectory, and they may already have a diagnosis of mild cognitive impairment, or they may be further along and already have a diagnosis of dementia. And I'll talk specifically about what the differences are between each Okay, so what is mild cognitive impairment? So if you've gone beyond the cusp of having age-related changes and you've lapsed into mild cognitive impairment, it's objective evidence of impairment in memory and other cognitive domains, okay, but with preserved ability to function from day to day. So even though these deficits are there, your daily functioning is not impaired. You're able to get on and do what you're always doing without it being significantly impaired. So you're able to do what's known as basic and instrumental activities of daily living. So basic activities of daily living are things like washing and dressing, being able to look after yourself. Instrumental activities of daily living are things like navigating or negotiating your finances, cooking, driving, managing your medications, okay? So with mild cognitive impairment, there may be deficits in all of the 6 domains, but you're still able to function. And this is essentially a condition that needs to then be monitored, because there is the possibility that this will progress along a trajectory and lapse into a dementia. So with mild cognitive impairment, there's different types of mild cognitive impairment, okay? So you have the type that will specifically affect memory, which is what we all talk about, and that's, as I said, the kind of catch-all phrase. But there's also types of mild cognitive impairment where memory isn't necessarily affected, but the other domains we discussed can be affected, like language, visuospatial skills, executive dysfunction, okay? So you can have amnestic, which refers to memory, and non-amnestic. If you have amnestic MCI, you're more likely to be heading down the trajectory of developing Alzheimer's dementia, okay? Whereas if you have non-amnestic MCI, you're more likely to be heading down the trajectory of developing a different type of dementia, like frontotemporal dementia or Lewy body dementia. And we'll talk, as I said, talk a little bit about that. So in relation to MCI, if you're given a diagnosis of MCI, the first thing people want to know is, well, what does that mean? And what does that mean in relation to developing a diagnosis of dementia? Am I going to develop a diagnosis? What can I do to prevent that? So approximately 33% of cases of mild cognitive impairment will actually just remain static and they won't progress. And even though you could do repeat testing every year, they stay relatively steady. There is also a portion who will actually revert back to normal functioning because they may have had reversible factors playing a part, like low vitamin D levels or a combination of medications that were impacting on their cognition. And when those culprits are removed, their cognition improves. On average, about 10 to 15% of cases of mild cognitive impairment will convert to dementia within a year. And the majority of patients who are going to transition along that pathway will do so within 3 to 4 years. And definitely 80% or more will have transitioned if they're going to within 10 years. Okay, so that's mild cognitive impairment. So if you then progress along the trajectory past mild cognitive impairment, so as I said, with mild cognitive impairment, the deficits are there in memory and potentially in the other domains, but you're able to function. So your ability to function from day to day isn't impaired. What happens when your ability to function becomes impaired? That's where you transition and you're lapsing into a diagnosis of dementia. So dementia is basically a group of neurodegenerative disorders. And what that means, it's a brain disorder. And neurodegeneration means basically degeneration of your brain. It's basically where the brain begins to shrink and atrophy. And I'll talk about why that happens. So it's a neurodegenerative condition characterized by decline in one of the domains. It could be language, learning, executive function, complex attention, visuospatial or motor or social cognition. And it represents a decline from your previous level of functioning, but it also has to be severe enough that it is actually affecting your daily functioning. So initially, your instrumental activities of daily living are going to be impaired initially, but as the disease progresses towards the later and end stages, particularly of Alzheimer's dementia and certain other dementias such as vascular dementia, the basic activities of daily living, your ability to care for yourself, feed yourself, wash yourself, those skills will go at the later stages of the condition. And the deficits in memory and cognition do not occur exclusively in the context of a delirium, which I mentioned earlier, because that's a reversible cause of dementia. Although people with dementia, as I said, are more vulnerable to developing delirium and are not better explained by another condition, as I explained, something like depression, where you're presenting with a pseudo dementia. Okay. So if you're given a diagnosis of dementia, we'll talk a little bit about what you do. But first of all, I just want to talk a little bit about dementia, because dementia is really a kind of tsunami that's about to happen in the next 10, 20, 30 years at a global scale, because our population is growing older in general. But specifically looking at Ireland, there's over 64,000 people in Ireland who have a diagnosis of dementia, and that's estimated to double before 2045. And on average, there's about 180,000 people in Ireland who are currently or have been carers for a family member or a partner with dementia. And a lot of people provide support that's really kind of undocumented or not recorded. So there's probably a lot more people involved in the care of individuals who have memory deficits and dementia. There's about 11,000 new cases each year, and that on average is 30 cases a day of dementia being diagnosed in this country. And 1 in 10, so 10% of individuals are under the age of 65, which is basically early onset dementia, essentially. Now, specifically for Alzheimer's disease, frontotemporal dementia does have a tendency to occur before the age of 65, but in the case of Alzheimer's disease, that's early onset. And the overall cost of dementia care in Ireland is almost, kind of like 2 billion per annum. So it's a significant emotional and economic and personal burden for many, many people who develop a diagnosis of dementia. And it can often be very difficult for them to navigate the pathway forward in a country where there's often limited resources to manage this. So then I know this is a very bright slide, it's to wake everyone up. And it was just to look at the global impact of dementia. And really what the slide is telling you is that every 3 seconds in the world, someone has been diagnosed with dementia. By the time of 2050, they estimate that there'll almost be 132 million people with a diagnosis of dementia worldwide. And the cost of that is huge. And it's a growing concern throughout basically the first world countries, but also third world countries where there's a higher portion because there isn't obviously the resources, and socioeconomic conditions mean that people with cardiovascular risk factors and other risk factors developed for dementia are not being managed appropriately. And so the prevalence of dementia is also rising in those countries. So moving then on to dementia. Okay, so I've been speaking about dementia as this overall term, and it is kind of a catch-all kind of umbrella term for a variety of different conditions. So there's many more types of dementia than the ones I've basically mentioned on this, but these are the main ones I'm going to focus on, primarily the ones that are most common. So dementia, as I said, is an umbrella term for a collection of symptoms. It's a neurodegenerative condition, and it impacts on our ability to function along with having these deficits. So the most common type is Alzheimer's. The second most common is vascular dementia. You then have Lewy body dementia, which overlaps with Parkinson's dementia, which I'll talk about. And then you have frontotemporal dementia. And then there's a lot of other dementias that are secondary to other neurological conditions, such as Huntington's disease, HIV infection, alcohol related. You've got CJD, lots of other very rare forms of dementia that can also present, but we won't focus too much on those because they're kind of more on the rarer end of the spectrum. So I want to talk a little bit about Alzheimer's disease because it is the most common type of dementia, and it's the one that people are probably most familiar with. So Alzheimer's disease, as I said, is a neurodegenerative condition, and it's primarily, its signature symptom is basically progressive loss of memory and deterioration in cognition. And like all of these conditions, unfortunately, it's not reversible. Okay, it's a progressive condition. Okay, so it's going to progress. How fast it progresses and how quickly someone moves along that trajectory, no one really knows. On average, if someone has a diagnosis of dementia, the life expectancy is about 8 to 10 years, but it can be up to 20 years. It really is dependent on a lot of factors and overall care and resources. Okay. As I said, it's the most common type of dementia. It really represents up to kind of 3/4, 75% of the cases of what we see. It's more common in females, so 1 in 6 females versus 1 in 11 males. And that's not just because females live longer. And we know that age is an unmodifiable risk factor to dementia. There's actually far more complex reasons for that are now being investigated, including hormonal and genetic and epigenetic reasons why that's the case, but it is more frequently occurring, higher prevalence in females. And the main areas that are affected are language, behavior, and memory. And the average age, usually, as I said, below 65 is early onset Alzheimer's disease. Okay, the majority are going to be after the age of 65. So 5% of people from 65 to 74, 13% of people between 75 and 84, and 33% of people, the percentage is occurring over the age of 85 and older. And Alzheimer's disease is essentially, a leading cause of death both in the US and worldwide. And interestingly, new research concerningly has shown that people who are over the age of 65 who have been exposed to the COVID infection, who've had COVID previously, are a significant increased risk of developing Alzheimer's disease. And we don't actually know why that is. We don't know why. Is it some type of inflammatory process where they're already on the pathway to developing Alzheimer's, and basically the COVID infection has just exacerbated them and pushed them along that pathway so that they're lapsing into Alzheimer's disease at an earlier stage? Or is it a de novo process? It's a new process that's happening that we don't fully understand. But the prevalence of Alzheimer's disease is certainly on the increase. So what actually is happening with Alzheimer's disease, and what it is that you're getting, as I said, you have neurons, which are basically your brain cells. And we have 85 billion neurons in our brain, okay? And they're all interconnected and working through different networks and circuits all the time, active to allow us to function and to think and to be able to react and respond. And what happens in Alzheimer's disease, years before the disease even develops, is that you get these abnormal proteins, which were referred to basically as plaques and tangles, so neurofibrillary tangles and these amyloid plaques. And they're essentially just abnormal toxic proteins. And what they do is they begin to kill off neurons. And this is happening for years and years before the disease even develops or presents itself, up to 20 years beforehand. And eventually what happens, it's like a seesaw, and it just tips over and cascades. And the amount of neurons that die off as a result of these plaques and tangles cascades over, and it presents then with deficits in memory. The difficulty is that these proteins, these abnormal proteins, attack specific areas of the brain. Initially, the temporal lobes, where, as I explained, your hippocampi are, which are these memory seats that store our memories and allow us to store our memories. Hence, in Alzheimer's disease, where short-term memory becomes a problematic, or an ability to kind of encode and then to transition that information into long-term memory. But also language becomes problematic, because our language centers are also in our kind of frontal parietal temporal lobe areas, so our ability to understand the spoken word, appreciate it, and to understand the written word. And then also behavior can change as well in Alzheimer's disease if the frontal lobes become involved. And eventually, as the disease progresses, all of the domains can be affected, because all of the brain will be affected by these abnormal proteins, and all of the brain will start to shrink and atrophy. So like all dementias, particularly Alzheimer's disease, it progresses through different stages of mild, moderate, severe, and end stage. And while I don't want to focus entirely on kind of the negative picture here, but it's having an understanding that the speed at which someone progresses through this, it's, as I said, it's very difficult to know. It really does depend on each individual. Some people are going to progress more rapidly, 4 to 5 years. Other people, as I said, it can be 8 to 10. And sometimes in very cases, it could be a very slow progressive condition, and it can take up to 20 years. In the end, the majority of people who die from a dementia, they're usually not dying from the dementia itself. What they're dying from is usually the consequences of that. So they eventually lose their ability to speak, their ability to function, and eventually the swallow goes in the end stages of dementia. And often what people eventually pass away from is that they will get an infection because they aspirate, because their swallow becomes impaired. And that's usually what will be the cause of their death, rather than actually being the Alzheimer's disease itself. And in the later stages, just that ability to function entirely will go, and often language will go entirely. But it can be really in the later stages before those type of deficits evolve. So then looking at vascular dementia. So vascular dementia is a different type of dementia from Alzheimer's. And often, to be honest, the majority of people probably present with mixed vascular and Alzheimer's dementia. You know, I think I'm yet to see a brain scan of someone with Alzheimer's dementia that doesn't have vascular changes, okay? So the majority of people who even have Alzheimer's disease are probably going to have an element of vascular changes as well, contributing to their condition. So vascular dementia is really as a result of damage to brain vessels in the brain, to blood vessels in the brain. And it results in basically a reduction in the flow of blood, the flow of oxygen to the brain, providing nutrients and oxygen. And as I said, it leads to these tiny, tiny little strokes, mini strokes, or these tiny little clots shooting up into the brain that are called microemboli. And when they cause the death of neurons in certain areas of the brain, they can be quite strategic, and they can result and manifest and present with specific deficits in different domains, depending on where these tiny little strokes happen in the brain. And kind of an overall term for that is referred to as vascular loading. So as I showed you in that scan, all of those white changes, I refer to that as, oh, there's extensive, well, that scan didn't show, but it can show extensive vascular loading. And that would suggest that someone could be well on the trajectory towards developing a vascular dementia if they're presenting correspondingly with cognitive deficits as well. So the risk factor for strokes is the same as the risk factor for dementia, which is high blood pressure, diabetes, high cholesterol, smoking, and heart disease, all of which are something that can be managed and modified through lifestyle changes and what we call lifestyle medicine, which I'll talk a little bit about. So again, the age of onset is usually 65 or older, and it's the second most common, about 20% of cases, okay? And as I said, the majority of times it may present with Alzheimer's, but people with vascular dementia mightn't necessarily present with any memory deficits. It could be actually deficits in other domains, specifically language and executive functioning, because if you get strategic infarcts to the language domains or to your frontal lobes, which help you to control and manage your executive, your higher mental functioning, they're more likely to occur, present with vascular. So often in the early stages of vascular disease, someone will not have any evidence potentially of memory deficits, but the other domains will show evidence of deficits. You then have I suppose, what we call the third most common type of dementia, which is Lewy body dementia. And Lewy body dementia and Parkinson's dementia actually overlap and are quite similar. And they're responsible for about maybe they occur the average age is basically lower, okay? It's about in your 50s, and it's responsible between kind of 15 to 20% of cases, or slightly lower in general. And this type of dementia is not caused by plaques and tangles, which is what we heard in Alzheimer's. It's not caused by damage to blood vessels, which is what's caused in vascular dementia. It's caused by these other type of proteins that are called Lewy bodies, okay? And they're toxic, bad proteins that develop over years in our brain. And depending on what area of the brain they develop really determines whether you develop a Lewy body dementia or whether you develop Parkinson's disease, okay? So Lewy body dementia is where these abnormal bodies called Lewy bodies, they develop in specific areas of the brain that are involved, let's say, in thinking and memory and these cognitive domains. Whereas in Parkinson's disease, they primarily and first of all occur in the areas of the brain that control motor functioning. And as I said, even if it's the case that someone develops Parkinson's disease, eventually, even though the Lewy bodies are occurring in those cases in the area, the basal ganglia, which is in kind of an area in the middle of your brain, that these Lewy bodies occur in, that cause the deficits that you see in Parkinson's disease. So the rigidity and cogwheeling rigidity, okay, and the ability to move and freezing, etc., and a shuffling gait. Eventually, those Lewy bodies will move from that area of your brain called the basal ganglia to all of the other areas like your memory and your frontal lobes, and then cause basically a dementia where all the other domains are being affected as well. So sometimes there can be difficulty in differentiating between Lewy body dementia and Parkinson's dementia. So with Lewy body, the dementia is going to develop before the motor symptoms, whereas with Parkinson's disease, the motor symptoms develop first, and then the dementia, the memory, and the other behavioral changes will occur second. Okay, so this is just to kind of give you a picture. Sometimes people in the initial phases, it can be very difficult to differentiate actually between Alzheimer's disease and Lewy body dementia. And you might think that's strange because they do present quite differently, but in the early stages, it can be quite hard to tell the difference. But one of the key features with Lewy body dementia is REM sleep disorder. And REM sleep disorder is a type of sleep disorder where you act out in your sleep and cause quite disturbance. So you can hit out, you can be talking, you can, and it's a very prominent condition. And it can actually happen for almost up to 20 years before you actually develop Lewy body dementia. And the other key feature that happens in Lewy body dementia that is less likely to happen in Alzheimer's disease is the development basically of hallucinations, particularly visual hallucinations, okay, and also kind of delusional beliefs. And the other key is that they develop what's called autonomic instability, which is basically inability to control blood pressure. So they often have hypertension or hypotension. They have a tendency to have a lot of falls, a lot of fainting episodes. So that's one of the key things that can be noted that's different or may vary from Alzheimer's dementia as well. And there can be a lot of fluctuation throughout the day. So even though with Alzheimer's disease in the advanced stages, there can be a lot of confusion, with Lewy body, that confusion can be really acute for even a short period of time, like an hour or two, and then someone can be more lucid and coherent for an hour or two, and then later on the day they can become acutely confused as well. So that fluctuating cognition throughout the day can be a sign more so of Lewy body rather than Alzheimer's dementia. And then I just wanted to mention frontotemporal dementia. So frontotemporal dementia is far less common. It's kind of between 2 to 5% of cases of dementia. And this is a particular type of dementia where often the memory is not impacted at all, because the area of the brain that shrinks is actually the frontal and the temporal lobes. And the memory seats are often preserved, particularly until later on in the condition. So the average age is younger. So this is what I was saying. Some conditions do develop earlier. So between 45 to 64%, about 60% of cases are going to occur during that age cohort. So there's usually quite a young onset, which understandably can be very concerning and frightening for the individual and also for their family. And as we said before, the frontal lobes are responsible for our higher mental functioning, so our social cognition and our executive functioning, so our ability to solve problems, to navigate information, to make a decision, some language, our personality, our ability to have inductive reasoning, our ability to think abstractly, our ability to what's called mental flexibility, moving between different tasks and navigating that information in your head, controlling your emotional responses, and being able to navigate social interactions. That's our frontal lobes are able to control those skills. So when you have frontotemporal dementia, they're the skills that become evident and begin to change. So people with frontotemporal dementia will often present with a change in personality. They may have gone from being a very passive person to maybe developing aggression. They may become quite apathetic, indifferent, lose the ability or the motivation to engage in activities they'd previously be involved in. And one of the signature features is basically what's called hypoorality, which is often can be a really key to someone who's developing frontotemporal dementia. They get a carbohydrate craving, so their dietary preferences change, and they have a tendency to have hypoorality, which is this frenzied eating, so this need to eat continuously although they're not hungry, specifically with having a very sweet tooth, so they're craving carbohydrates and eating sugary or sweet food. That's one of the key features. Now, it's kind of it's a type of condition, and there's actually a few subsets of it. So it can affect language if the language centers are predominantly affected by this condition. And then there's also a behavioral variant. And with the behavioral variant, it's these conditions like loss of apathy, change in personality, disinhibited behavior, being socially inappropriate, and then this carbohydrate changes that you see, where the language variant is predominantly language deficit. So you lose the ability to be able to communicate, you lose the ability to understand language, and also to be able to communicate as well, which understandably can be very frustrating and distressing for someone who's aware of these deficits but just can't communicate because of this inability and because of this condition. So I just wanted to highlight from the point of view of the lobes of the brain. I had explained earlier that obviously the brain is divided up into lobes, and each of these lobes hold or have the ability to do different mental functionings or mental abilities or thinking abilities, these cognitive domains. And different types of dementia, as I explained, can impact the different cognitive domains depending on what area or what lobe of the brain is being affected. So as I said, frontotemporal dementia is primarily the frontal and the temporal lobes. In Alzheimer's disease, you're looking at more of the temporal parietal lobes that are being affected. And as I explained, then depending on what lobe is affected, depending on how someone presents. But as most of these conditions progress, there's usually global changes to the brain. So as they enter their advanced stages, you're going to get more global changes occurring and overall deterioration in all domains as the condition progresses along that pathway. Okay, so when someone is given a diagnosis of dementia, often what causes the most distress is actually what's called BPSD, which is the behavioral and psychological symptoms of dementia. And up to 90% of patients who were given a diagnosis of dementia, be that vascular dementia or Alzheimer's dementia or frontotemporal dementia, or even Lewy body dementia, will exhibit what is called BPSD, and it can be very difficult for carers. It can cause significant carer burden and also can be very distressing for individuals themselves. And the main features can be anxiety, apathy, a disinhibition, which can cause a lot of distress, can also sometimes lead to kind of inappropriate or aggressive behaviors. Hallucinations, particularly in Lewy body dementia, that's quite frequent. Sleep changes, again, that can, as I said, occurs in Lewy body dementia. Difficulties with personal care, so lack of interest in wanting to shower, not wanting to change their clothes, wanting to exit seats, so looking to leave the home even though it wouldn't be safe for them to do it because they'd become really disorientated if they were to leave and they'd be at risk of misadventure. Often then you can develop psychotic symptoms, okay, which is the kind of neuropsychiatric sequelae of dementia, and that can be paranoid ideation, and they often begin to misidentify people. Often patients who become paranoid and they're in the advanced stages of dementia think that someone is in their house. They can become really agitated, thinking people are breaking into their home. They can develop delusional beliefs. It can be very distressing and hard to manage if those delusional beliefs are about family members or about their carer. And also there can be a component of mood. And people who develop dementia can become depressed secondary to the dementia, and that needs to be proactively treated. So we try to manage BPSD as best as possible through behavioral management strategies and through psychoeducation and through kind of behavioral support plans. But sometimes medication is required in order to manage these symptoms, and medication can be very effective. Again, you have to be very cautious and balance that with the type of medication that you're going to prescribe, because some medications that would be used, such as anti-anxiety medications, antipsychotic medications, antidepressant medications, can in themselves increase the risk of further cognitive decline or cognitive blunting, and they can increase the risk of cardiovascular risk factors in patients who have dementia. So we have to weigh in the balance the benefits of prescribing these medications. But if you're presenting with someone who has significant difficulties with behavioral and psychological symptoms of dementia, there's significant aggression, there may be violence towards a carer, and there may be significant difficulties with personal care, there may be benefit, particularly as well if there's anxiety or depression. It's very important that that's proactively treated, and can improve with medication and very, very close monitoring. So then, if you're given a diagnosis of dementia, what do you do with that? Like, where do you go with that? What, you know, can be very, when we see patients in the memory clinic and we make a diagnosis of dementia, the first question always is, well, what do I do now? Like, what do I need to do? Is there something I need to do right now? So there's certain advice and kind of practical advice that we give all patients who are moving along that trajectory from, let's say, mild cognitive impairment to a diagnosis of dementia. And it's about just establishing and sorting things moving forward so that things can be, their affairs can be managed and they can function and manage safely moving forward. So one thing that we would always recommend, if there's any concerns in relation to visuospatial deficits, either having a diagnosis of mild cognitive impairment or if you have a diagnosis of dementia, is driving. And we'd always recommend that someone has an on-road driving assessment. Now, the Irish Wheelchair Association have a list of on-road driving assessors. And this isn't like doing a normal driving test. So you're not expected to go back and do that. What it is, it's done in your own car. It's done in your locality. And someone essentially is assessing you to determine that it's still safe to drive. And I suppose the most important thing to say is having a diagnosis of mild cognitive impairment or dementia does not mean that you have to stop driving. If anything, that may not necessarily be a good thing if driving is what allows you to remain socially engaged. But what's important is that if you are driving, that you're safe to do so and that you've been determined to be safe to do so. So when you have an on-road driving assessment, it may be the case that you're told it's safe to drive. It might be the case that there's certain conditions put in your driving. They may say you can only drive within your locality, or that you should not drive at night, or you might be told, look, it actually isn't safe to drive. You also, it's important that you tell your insurance company, and also the National Driver's License Service provides a lot of information to help people navigate this whole process. The other issue that's very important in someone, and this really relates to capacity, and I won't go into that in too much detail because that would be a whole other talk and outside the scope of this talk in many ways. But obviously, as someone develops cognitive deficits and cognitive impairment, the concept of capacity and their ability to make an informed decision and to be able to weigh up and measure information and apply it to their own circumstances in order to make an informed decision about something can be compromised if they develop cognitive deficits. So it's really important that someone, even before they've developed cognitive deficits, everyone should consider doing what's known as an enduring power of attorney. Now, there is an existing enduring power of attorney, which is the existing form of this is under the 2015 Act, but there's a new Capacity Act that's about to come into play and be invoked, and that's going to most likely be next year. Now, it was meant to be in the summer of this year, but it's likely to be 2023. But there is a lot of information available on the Citizens Information website, and an enduring power of attorney is really a safeguard. And what it is, it's where you make a decision to nominate an attorney, which is basically a member of a family or a close relative or someone who understands and knows you. So if or when circumstances arise that you no longer have capacity to make informed decisions about your care and welfare and your finances, this individual can take over making those decisions. But it can't just happen. So what will happen is, when you make an enduring power of attorney, it's essentially a document that you lodge with your solicitor. You're deemed initially to have capacity to make that and to nominate your attorneys, essentially. It then just is stored. And it's only when or if a time in the future that your capacity comes into question. So, for example, you've had mild cognitive deficits, but you progress along that trajectory and you lapse into a diagnosis of dementia. And as you progress along that course, you may lose the ability, because of the progression in your cognitive deficits, to make an informed decision and a measured decision about your care needs. And at that point, when your capacity comes into question, a further assessment will take place where an old-age psychiatrist or a doctor or a geriatrician or a neurologist will see you. They will assess your capacity, which is a formal assessment of capacity, and determine at that point whether you've lost capacity. And then a decision is made where the enduring power of attorney is essentially donated and your attorney will take over making decisions on your behalf with your best interest at heart. So it's really important that people consider doing that even before they have deficits. I think it's something that everyone should do because it is a safeguard and it's important to have that moving forward. I wanted to talk a little bit about supports and resources. So when someone comes, as I said, to the memory clinic, they're always looking for information, or they're looking for resources, or where do they go to and how do you signpost them? And there's certain resources that are better than others. So the Alzheimer's Association is an excellent resource when it comes to, for carers in particular. There's a lot of information for carers, but there's also a lot of information about basically dementia in general, about management of it, about treatment care plans. There's a lot of resources available. The Dementia Support and Information Service also has a lot of information. We now have what are known as basically memory and technology rooms. So I've given the link here for the one that's in Clonskee, but there is a number of them around the country. And these are really good for individuals who have a diagnosis of dementia and also their carers. And it gives you access to different assisted technology that can help you to live a better life, even with your dementia, okay? You then have Hello Brain. I don't know if anyone's heard of that. It's basically a service that's run, a program that's run in Trinity College, and it's an excellent resource and website that teaches all about your brain. It teaches all about the different functionings of your brain, it teaches you a lot about cognition and memory, and there's a lot of resources available about dementia and about the changes that happen as someone progresses along that program. Harvard Health Publishing, okay, which is kind of under the auspices of Harvard. It's obviously a US resource. They do online programs looking at cognitive fitness and improving memory. And they're really good programs. They're very easy to follow. Now, they are a paid for program. They're not very expensive, and they're usually modular, and you can go in and engage in these programs, but they're really good for teaching you about memory deficits, and what you can do to reduce or modify your risk of developing cognitive deficits and dementia moving forward. And it's a very positive spin and about empowering individuals to take control and to basically exercise your brain like you do any other muscle. Like if you don't exercise it like any other muscle, you're going to lose it, and the brain is no different. So it's a real focus on the importance of brain health. The Cambridge Memory Manual is a really very simple, practical, but really effective tool. It's downloadable, it's free, it's available in multiple languages, and it's filled with really practical steps for someone who has memory deficits or has a diagnosis of dementia, not only for the individual, but also for their caregivers. The Center for Brain Health, which is based in Dallas in Texas, is a fantastic resource. There's lots of really good lectures, lots of amazing information about the most up-to-date, research that's looking at basically all different types of dementia, but also there's again a focus on how you maximize and optimize your cognitive reserve. There's a large portion of it is about cognitive fitness. It's about brain health. And again, it's a very positive outlook on how you can empower yourself to manage these deficits and minimize the risk moving forward. And I just also mentioned DBMAS, which is an Australian-based service. It's the Dementia Behavioural Management Service. And for individuals who do develop dementia with BPSD, these behavioural and psychological symptoms of dementia, it's a really good resource for information about behavioural management strategies, behavioural support plans for carers, and a lot of information about the different types of symptoms people can present with and how to manage them, be that apathy, agitation, etc., etc. So a really, really good and effective resource and easy to follow. So just towards the end of this talk now, I really wanted to focus on, I suppose, something quite positive, and it's about empowering people to have and understand the importance of brain health, and looking at the risk factors that are modifiable for memory deficits and for dementia. So there's certain factors that are out of our control, and there's nothing we can do about that. So the first one obviously is age. As I said, as we get older, we're at risk of cognitive decline that can lapse into mild cognitive impairment, that can lapse into dementia. So there's nothing we can really do about that age. We can't reverse the time. We can't stop ourselves aging. Race and ethnicity as well is more newer research basically shows, for example, that African Americans have a higher prevalence of developing Alzheimer's disease, and Latino of Latino origin, particularly in the States, compared to other ethnicities. We're not really quite sure why that is. It could be a socioeconomic component, that they've higher cardiovascular risk factors, etc. But we're not really quite sure why that is, but they do have a higher prevalence. So again, that's something that you can't really change or modify. And clearly genetics is key to it too. So you always hear about the genetic, people always say, if my family, my father has Alzheimer's disease, am I going to get it? And there is significant genes that are associated with different types of dementia. Most commonly, you always hear about Alzheimer's disease, and there is a genetic predisposition to that, also to Lewy body and to frontotemporal dementia. So for example, in Alzheimer's disease, there's a certain gene which is called the ApoE protein. It's the gene that I explained earlier on, that individuals who have Down syndrome have an extra copy of this gene, hence why they have a higher risk of developing Alzheimer's disease. But if you inherit one copy of that from one of your parents, you're 4 times more likely to develop Alzheimer's disease. If you unfortunately inherit a copy from both parents, you're 12 times more likely to develop Alzheimer's disease. But with that said, that doesn't mean you're definitely going to develop Alzheimer's disease, because we now know that there is modifiable risk factors that can offset the genetic risk factor for these conditions. And these are within our power to change. So if you look at this first graph here, this was published a number of years ago. The Lancet Commission did this, and it basically was looking globally at dementia and looking at what factors are modifiable versus what are the risk factors that we cannot change. And they identified that actually there's potentially 40% of cases worldwide of dementia are as a result of risk factors that could have been modified, okay? So education, understandably, 7% of cases. Hearing loss, so that's something I was going to mention, is that if someone has deficits, it's really important that you optimize. So if they've got glasses, they wear their glasses, and if they've got hearing aids, they wear their hearing aids, because you're going to cause a more rapid deterioration in their deficits if you're causing sensory deprivation and they're not hearing or seeing properly. Traumatic brain injury, as I said, is an unusual case, and I explained about that condition that can happen. Hypertension, so these are cardiovascular risk factors. So hypertension, alcohol, so greater than 21 units a week. The recommended intake for males is 14 units and for females is 11 units per week. And even that, you shouldn't really be drinking that much. And when patients come to the memory clinic and, you know, I would be engaging with them, I would always say, well, try to minimize a couple of glasses of wine a week, that's fine, but try to minimize the amount of alcohol that you're taking in. Obesity, smoking is a huge one. Depression, which we spoke about, and pseudo depression. Social isolation, there's more and more research looking at the role of social isolation. And we now know that loneliness and social isolation is a risk factor in itself for developing dementia. Physical inactivity, so the importance of exercise, air pollution, and diabetes. These are the risk factors that occur later in life. So there are modifiable risk factors, and that we can play a role in modifying our risk. And some research would show that even if you have a genetic predisposition, so you carry an ApoE, let's say, gene for Alzheimer's disease, but you decide to engage and adhere to these lifestyle and modify these risk factors, you can still reduce your risk of developing Alzheimer's and offset that risk that's been triggered basically by having that inherited ability or that susceptibility. So what are the modifiable risk factors for developing memory impairment and dementia? Okay, so the first one is exercise. So exercise is so good for you in so many ways. It's not just good for reducing your risk of developing cognitive impairment and dementia. It basically reduces your cardiovascular risk factors. And by reducing your cardiovascular risk factors, you're reducing your risk of developing other conditions like dementia, mental illness in general, diabetes, etc., and also heart disease. So engaging in exercise is very important, and it's very important that you engage in basically aerobic exercise. So you're getting your heart rate up and you're going out and walking, or you're exercising, you know, at least 3 times a week, if not more. And if you engage and you do exercise with other people, so that you're not only exercising, but you're remaining socially engaged and cognitively stimulated, that's even got a more beneficial effect. So it's really important that you maintain your exercise. And a lot of people, when they're older, because of other physical comorbidities, struggle with that. So they might find it hard to run or to walk. Well, then they should swim, or you should engage in some activity that allows you to exercise the body, because by exercising with your body, you're helping to keep your brain, which is another muscle, exercised also. Smoking is a huge risk factor for cardiovascular health, and it's a huge risk factor for development, therefore, of vascular dementia. So smoking is just something that shouldn't happen. You know, minimizing smoking is really important. Diet is also very important. Now, before, the approach was have a balanced diet, you know, eat everything in moderation. We now know in particular that there's certain types of diet, like a Mediterranean based diet, that there is an evidence base that does decrease your risk of developing a dementia. And that is the type of diet that's higher basically in unsaturated fats, in pulses, in vegetables, and in grains. Okay, and we know particularly females who have a diet with the higher saturated fats are increased risk of developing a dementia, okay, and Alzheimer's disease. So diet is very important, and obviously managing as well your fasting glucose, so you don't develop something like diabetes, which again, as a chronic illness, increases potentially your risk of developing deficits and dementia. Remaining cognitively engaged. So this is about minimizing social isolation, remaining cognitively stimulated, engaging in activities that you enjoy doing. So it might necessarily be doing a word puzzle or a Sudoku. It could be playing bridge or playing bingo, or engaging in any type of cognitively stimulating activity with your peers. But also evidence has shown that if you engage with people of a younger generation, so intergenerational engagement is even more beneficial than just engaging with your peers. So engaging in things like intergenerational choirs or anything that involves engaging with younger people. Getting involved with volunteering with a younger cohort has benefits for both cohorts, but particularly for older adults in remaining cognitively stimulated. As I said, cardiovascular risk factors is another significant thing that it is within our power to manage. So very tight control of blood pressure is essential. So if you have concern about your blood pressure and you're worried about it, you should go and see your GP and get a 24-hour blood pressure monitor if it's a concern. And there's also these concerns about your memory and cognition, sometimes something that we often recommend in patients who are presenting with mild cognitive impairment, and particularly if they have a lot of vascular changes in their brain, and also ensuring that your cholesterol is within normal range. And if you need to do that through diet or through medication, it's about speaking with your GP about that. And then, as I said, other chronic illnesses, managing other chronic illnesses, such as diabetes. So sorry, just before I finish, the other thing I wanted to mention was sleep and the importance of sleep. So we now know in recent years that sleep plays an essential role, not only in our ability to encode, so converting short-term memories into long-term memories and embedding those memories, but we also know now that having what's called restorative sleep or stage 4 sleep is the sleep that allows our basically janitor system in our brains to flush out all of those abnormal proteins that I was talking about earlier on that lead to Alzheimer's disease. It's in stage 4 sleep that we flush out all of those proteins. So it's essential to have a really good routine when it comes to sleep, so that you're getting restorative sleep and that you're getting stage 4 sleep, because as we get older, we're less likely to get that sleep. So focusing and having a routine around sleep hygiene is really important. So they're the main factors that are associated, that are modifiable, that we can play a role in minimizing the risk of developing memory deficits and potentially dementia. And it's really important that people understand that these are referred to as kind of lifestyle medicine, and it's within our ability to make these changes to minimize risk moving forward. And that's it.
Thank you so much, Dr. O'Dwyer. That was a really fantastic, informative presentation. We don't have any questions in at the moment, so it was very comprehensive. I think if anybody has any questions in the next couple of days, you can feel free to get in touch with us via our support and information line. The recording of the webinar will be, as I said, uploaded to the website in the coming days, so it will be there for you to come back to with lots of the resources that Dr. O'Dwyer has mentioned throughout the presentation. So thank you all for attending, and thank you to Dr. O'Dwyer for joining us this evening.
Thanks, Elaine.